I'll mention that I'm in this little state of Rhode Island, and we now have a perceived primary care crisis because there's a practice that decided to close, a practice of about 25 clinicians with about 25,000 patients, decided to close with a couple of weeks' notice. So we've got lots of people scurrying around, and of course, there's no place else for them to see. No one else for them to see. So of course, everybody in Rhode Island uh, is on edge about primary care, and it's given us an opportunity to talk about the issues that are so important to us. I think we ought to get started. Alan, take it away.
So, welcome everybody. My name is Alan Roth, and I am a practicing family doc as well as chair of the Medicis Health Network's Department of Family Medicine, Ambulatory Care, and Community Medicine in Queens, New York. Additionally, I am a very proud member and vice chair of the board of Primary Care for All Americans. On behalf of the board, I want to extend a welcome to you all for tonight's Teach and Learn in Zoom session. Thank you all for joining us this evening. We now have over 1,400 people from 40 states, the District of Columbia, and more than 350 zip codes, and we are reminded of the incredible momentum we are building together to provide primary care to everyone in every American neighborhood and every American community. Thank you for your dedication and commitment to our movement. It is my great pleasure to introduce our moderator for this evening, Chioma Nwankwo, and extend my sincere thanks to all of the presenters to tonight's event. I'd like to thank the Primary Care for All American Zoom Committee, as well as John Wright, Brian Kaiser, Patty Armstrong, and Liv Verratti for organizing this event. Take it away, Chioma.
Hi, everyone. I'm Chioma Nwankwo from Houston, Texas. I'm an alumnus of Ross University School of Medicine and a prospective family medicine resident. I want to start by thanking all of you for being here tonight by joining us. You're helping us to build a movement, one that focuses on providing health care to people in every neighborhood and community, primary care for all Americans. If you haven't shared your community yet, please do so in the chat so we can all see who's here and work together and build this movement. Please continue to refrain from using professional titles. This space is about focusing on the importance of being here together, engaged in this work, and valuing the ideas that communities that will ultimately drive this movement forward. Tonight, we're here to both teach and learn from each other. We encourage you to contribute by submitting your questions in the chat throughout the session. Please stay with us till the end of the session, when we'll have time for a Q&A discussion. We'll explore how you can help bring primary care to everyone in your own neighborhood and community. Now, I'll hand it back to Alan Roth, who will introduce our speaker for the evening.
So it is my true and great pleasure to introduce tonight's speaker, Dr. Andy Lazris. Andy Lazarus is a practicing primary care internist and geriatrician. He attended medical school at the Albert Einstein College of Medicine and did his internal medicine training at the University of Virginia. He is double board certified in internal medicine as well as geriatrics. He is the author of multiple books, including Curing Medicare from Cornell University Press, Interpreting the Health Benefits and Risks, and his new book, which I am proud to have co-authored with him, A Return to Healing, Flexner-Osler and How American Healthcare Went Astray, was recently published by the University of Toronto Press. Andy and I first met at a Lown Institute Right Care Alliance meeting about 10 years ago, an organization that is dedicated to advocating for appropriate medical care for all. We quickly found out we had so much in common when we both quoted Sir William Osler, who to both of us was the epitome of a true clinician and scientist, who believed that science was essential to great medicine, but the patient is the true teacher, and whose medical care should be at the core of what we both believe is the art of medicine. Together, Andy and I have been dedicated to advocating and writing about appropriate and patient-centered medical care for all, and the movement for primary care for all Americans. Let's dive into tonight's topic. Andy, please take it away.
Okay, if I have to first share this screen. I'll do a quick PowerPoint. It worked, right? So hello to everyone. I'm Andy Lazarus. I'm a an internist, primary care. I do geriatrics, although I'm not board certified, but I feel like I am. I'm certified in internal medicine, and I've been loving primary care from the first day I walked into medical school. And back then, back when I graduated, half of my residency class went into primary care and remains in primary care. My son and daughter are both in medical school, and they say zero people in the years before them, the years after them, and their year will go into primary care. And when I ask them if they're interested, they just laugh and laugh. So it is a problem. It's the most wonderful field of medicine of all. So Alan and I wrote this book over many years. We actually finished it before COVID, and then we got derailed because of that. But we're thrilled to have it out, and it looks back at a decision made in 1911 when our healthcare system really started and put us on a path that diverged from everything that William Osler was teaching us about the patient. Things that William Osler said is if you want to know what's wrong with the patient, ask the patient. If you have a problem and take a medicine, now you have two problems. His quotes go on and on. But we use the idea of the Flexner Report, which occurred in 1911 with the help of the AMA and the Rockefeller and Carnegie Foundations, and the pharmaceutical industry to create a healthcare system that was designed to make drugs, and to sell drugs. And that's kind of where we are now. So we talk about that in our book. Um, there are aspects of this Flexnerian model that I want to talk about briefly, and also in the end go to the Oslerian model, which offers the best solution to our primary care crisis. Um, that's Mr. Flexner. He was not a doctor. He was friends of William Welch, who taught at Hopkins and who was a pathologist, a eugenicist, and the man who created our system. And the library at Hopkins is still named after him, despite the many things he did. And the Flexnerian philosophy is simple. Um, Basically it borrows the German idea that we don't have to talk to patients. In fact, talking to patients gets in the way, because patients are subjective. Patients will tell you it's a story, but the real truth lies in the body, through lab tests and other tests that have expanded since then. And if we could define normals and then send people to specialists to take care of their normals, then we will fix the abnormal measurements that we have and make them better. And all this has led to the disaster we called healthcare now, and which is why we have a specialty system. Why numerical measurements are dangerous? You guys know what numerical measurements are. They're, measuring an A1C, measuring cholesterol, getting a stress test, getting a bone density. They carve people up into these measurements. And that's really what it is. And they're all organ focused. So each specialist has their little organ they slice up. A cardiologist will do 20 tests, put people in my practice walk out of a cardiologist's office with 7 new medicines. They don't really care about what the medicines do to any other organ in the body. In fact, at least where I am, and this is across the country, when someone gets a side effect, let's say from a statin, which is a cholesterol medicine, um, and they can't walk, they have pain, the cardiologist will send them to an orthopedist. So the specialty jumping continues. And that's what we have lost. The patient themselves is lost in this maze of numbers. They are defined by numbers. And unfortunately, that detracts from holistic care and prevents us from having a primary care system. We have a system of drugs. Numerical diagnoses. There's an Osler quote: "The good physician treats the disease. The great physician treats the patient who has the disease." And there are various forms of this cartoon, but basically it shows the lack of common sense that runs through a system where we just want to measure things. So here's a guy with an arrow in his head. The doctor says, yeah, maybe that's what's causing your headache, but let's do some other tests. And in this case, a COVID test, but I've seen other things before. We've also created all these diseases. And we've created prediabetes and osteopenia and MCI and hyperlipidemia, none of which have been shown to correlate to real disease. Alan and I have written articles about this, but a lot of it's in our book. We have tons of references showing why these diseases not only are not real, but that they were created by drug companies and specialty societies. Um, Numbers create diseases and define normal. A PSA, which is a prostate specific antigen, as one example, will tell you if you have prostate cancer. And we know if you have prostate cancer and we treat you, we will get the PSA to zero. We can do that, but we will not be helping you live a day longer. So this discrepancy between number treating and patient treating has become the biggest problem. And the biggest problem we run into in primary care is that um, basically people who test for numbers are paid far more. People who fix things like a blocked artery that we know in an asymptomatic patient will not help you one bit, will be paid a ton of money. And all our call it indicators, which are designed by specialty societies on drug company studies, are based on numbers. So we sit there in front of our computer trying to fix numbers instead of taking care of patients. It's certainly not a primary care system. And to us, and in our book, this is what we need to address first and foremost. Um, just as important as the medical industrial complex, which we spend half our book talking about, and where there's no room for primary care. Um, the medical industrial complex thrives when you do all this testing. So, of the $4 trillion we're spending for healthcare in this country, it's felt by many groups that about half of that is waste. In other words, it doesn't contribute to patient care. I think it's much more than that that's waste because the people in the world that live the longest don't even go to doctors. But they certainly don't take all these medicines and get all these tests. I always say that, there are no statins in the blue zones, but there's plenty of statins here, and between specialty societies, which have huge presence in Congress, um, academia. No offense to, I'm non-academic, but no offense to anyone who is. But academia, there's barely an academic medical uh, hospital that is not financed almost entirely by drug company spending for studies. Media, Congress. Um, all of them are paid by drug companies. In fact, the drug companies pay the Alzheimer's Association, the American Diabetes Association, CDC, FDA. They all get most of their money from drug companies. And Big Pharma has truly defined what studies are done in this country and what we consider normal. They have defined the numbers that are normal and given us the medicines to bring those numbers back to normal. And all that fits into a specialty society. That's how people are getting paid. Um, so this is basically some of the stuff I talked about. In fact, the pharmaceutical companies say their best bang for the buck isn't bribing congressmen, isn't giving money to CNN and Fox, but is paying for the American Diabetes Association, American Cancer Society, American Alzheimer's Society, because people trust those organizations. So that pharmaceutical companies love to have trust. Um, so medicine is a science of uncertainty and an art of probability, says William Osler. Not true to the German designers of our healthcare system. There is a right and a wrong. It's binary. There's yes and no. And anyone who is a doctor, who is going to become a doctor, knows that you are graded on a multiple choice test. There's one right answer. In my world as a doctor, there's never one right answer. There are multiple possibilities. But again, one right answer fits right into specialty care. Convincing people that number fixing is the path to health has backfired. Over the last 25 years, the amount of money we spend went from 500 billion to 4 trillion. Longevity has gone down, chronic disease has gone up. There's also this dogmatic absolutism. So the idea that this one right answer, an example today, someone who falls down and has bled before was put on a blood thinner by her cardiologist and said, you'll get a stroke without it. Well, as I told her, you'll probably get a stroke on the blood thinner because of your risk, and studies show that. But she was so scared by the cardiologist who said, you will definitely get a stroke. You might even get one before you get home. And by the way, come in for a stress test, an echocardiogram, carotid ultrasound every year. And they say, thank you for being so thorough. This is the problem. This is our specialty system. But when you have a numbers oriented system where we fix numbers, this is what happens. And most of the studies that are used for our quality indicators, for the little calculators doctors walk around to tell you what exactly your risk is, they're all based on drug company studies. And they all push for more and more, do more. There's the most people don't know Marcus Welby. He was the old doctor, Robert Young. Uh, he was the old primary care doctor who came in. He knew everybody completely. He took care of them. He went to their houses. He spent time with them. And I guarantee you, Marcus Welby was not putting everyone in statins and checking cholesterols and bone density and calling people pre-diabetic. He was just taking care of them, and he was listening to them and talking to them, seeing what they wanted. And that's what primary care does. But again, in a system where we are fixing numbers and we're slicing things up and we're run by drug companies, Marcus Welby would be a member of this group screaming and yelling, and maybe that part of that group in Rhode Island that walked out and closed down. And we're getting, look, we most of us in this room, I hope, love what we do, but we're very stressed. We have among the highest stress in the country. When I ask my kids why they wouldn't go into primary care, their answer isn't that the pay is lower. And I will tell you, our pay is, in my opinion, fine. They're paid too much, but we're paid fine. The problem is they both said it's too hard. You got to know too much. There's too much stuff you got to do. When you're taking care of one organ, one a bunch of numbers, it's much easier. And then when there's a problem, you send them to another specialist. That's easier. But unfortunately, and you who teach residents probably know this, nobody wants the hard work of taking care of a patient in a system where everything is number based. So the administrative burdens, the lack of time, lower pay, the fact that only 5% of healthcare dollars flows to primary care, and the fact that we're judged by these same numbers that everyone else is. If I dare talk to my patient, for instance, about getting a mammogram and they decide not to, I get dinged. Having a discussion with a patient is a big negative. And again, that's what we do in primary care. And in our book, we talk about what we call cognitive dissonance, how people believe number-based diagnosis really hits our cognitive needs. If you have a 90% blockage in one of your arteries, the doctor found it because he did his annual stress test and he fixes it with a stent and says, I saved your life just in the nick of time. That feeds all our cognitive needs. We're like, God, thank God for that doctor. But they're no better off. And they might still be smoking and eating McDonald's, and that nobody cares about that because we don't care about the person. So William Osler, our guy, who, by the way, the Flexner report only came out after Osler retired. He went to England and he was mad. And he wrote a lot to Flexner. But at that point, the power of the Rockefeller Foundation with that only funded schools that had full-time lab faculty, and all the other schools fell apart. And I'm actually a master's student in the University of Maryland in history. And I did my thesis on the racial origins of our healthcare system. And yes, there were no African American physicians that were in a school that Flexner believed was adequate. And basically, they did not care about that. In fact, the Flexner report says the only reason to train African American, and he calls them hygiene workers, and he left two schools open for this, was to make sure they don't spread disease to white people. And this is what our healthcare system is based on. And the amount of information I found about the racial origins is just frightening. It is much more important to know what sort of patient has a disease than what sort of disease a patient has. I cannot imagine any of the cardiologists I work with making that statement. Um, but he feared greed. He was never a member of the AMA. He feared the pharmaceutical industry, which was at that point in the early 1900s already huge. Um, and he spoke to his students about this. And he believed that from day one of medical school, you should be with patients, that the lectures should come to supplement your patients. As soon as he left, they fired all the primary care doctors at Hopkins, and they just brought in full-time lab people, and that's what Rockefeller wanted. So we need a primary care system. I think everyone here agrees with that. whether the current Health and Human Service Secretary is going to do anything. I know he said he wants a primary care system. No one else has said that. Even the people screaming and yelling for universal health care have never said they want a primary care system or that we need to cut out specialty care. We need to eliminate drug companies from every tentacle of our healthcare system. They can no longer be advertising on TV. They can no longer be paying the CDC and FDA. And by the way, most of the CDC leaders who talk about anything from vaccines to viral treatments are former executives of pharmaceutical companies. There have been plenty of articles written about this. We need good data. We can't have pharmaceutical data. Cochrane is an example of the way to use good data. If anyone's not familiar with that, the Cochrane Library uses studies that are not funded by drug companies and does not get any money from drug companies. So, how do we get a primary care system? We have to um, we have to pay, obviously, more of the healthcare budget toward primary care, give primary care providers more time. Medicare is in charge of residencies in terms of payment. They could easily pay for more residencies for primary care and fewer for for specialty care. All this stuff I'm talking about could be done tomorrow. So it is easy. So the idea of and by the way, holistic lifestyle-based care is something Kennedy's talked about. But that's what we have to get to. We have to get to holistic lifestyle care that's primary care based. And we have to stop worrying about so many numbers. We have to stop paying doctors to fix things with tools. And we have to start paying for a system that actually takes care of patients. And that's what we tried to do with this book is to give a roadmap, both of what happened to lead us down this road, why it is so popular, why no one's fighting it, and what we have to do to change it. I believe from my own experience as a doctor and from feedback I've had that when you explain to them what a primary care based system would be and a non-numerical system, people get a little nervous. They say, "Well, it reminds me of a patient who I put on hospice, and she did better when she was on hospice because we stopped all her drugs. And then when hospice dropped her, the daughter said to me, "Well, shouldn't we be checking her cholesterol to see if she should go back on the statins?" It's like you don't learn. Your mom is better now because we stopped all the drugs. So it's hard because people are programmed to believe all this is right and normal, and they're afraid. There's so much fear injected into our system. So part of what we have to do is dismiss, not dismiss, but just to try to diffuse that to some extent. And that's we hope the book helps people to understand what the problem is and how to do that in a way that will make them healthier and actually increase satisfaction for everyone. Thank you.
So let me take 1 second as Andy's writing partner. Andy, thanks for representing us so well. We don't have a healthcare system. We have a market-driven system that's based on stupid numbers and profits over patients and pharma and hospital systems and insurance companies making tons of money. We pay twice as much as the next leading nation on healthcare, and we don't have a healthcare system. It's a dysfunctional mess. We don't live longer than anyone else, and until we have a system that's based on primary care, we're going to go nowhere. So Chioma, take it over. Thank you. Andy, thanks for such a great job.
Sure.
Love you.
You too.
Thank you, Andy. Wonderful presentation. Now we're ready to take some questions from the audience. If you have any questions or comments you'd like us to address, please feel free to post them in the chat. To get things started, I have a few questions. These questions are from Dr. Fine. You've helped us understand the difference between so-called scientific medicine and the medicine of listening and talking to patients and treating them as individuals. What does this mean for our communities who are trying to get everyone healthcare? Does it mean we need more clinicians per person or less?
Well, I mean, for us as primary care providers to truly be Oslerian, which is what we call them, and to spend more time and discuss things, yes, we do need more primary care providers because we can't be taking care of a million patients each. We have to have smaller panels. We have to have more time with our patients. that would save the system a ton of money if we were involved to that extent, where we just, primary care providers are so stressed right now, they just send people off to specialists right away. We do need more time. We also need a system where we are not being judged by how we fix people's cholesterol and how low we get their blood pressure. We have to be judged by having a conversation with the patient. I get it. Quality indicators are fine, but a quality indicator for mammogram is, did you discuss the pros and cons of a mammogram? That should be the quality indicator. So not whether they got it or not. So yes, we need more. We need people in my two kids' classes to go into primary care, and they will not do it unless we have a system that gives them more time and less burden. Those are the two big factors.
I think Sarah Pasteur had a question.
Yeah, hi Andy. This was so fantastic. I absolutely loved it, and I couldn't agree more with everything that you said. And thank you so much for sharing this book with us. And Alan, to you too. Looking forward to reading it. So your last slide there said that only a primary care-based system will work, which really speaks to our need to have a strong foundation of primary care. But I've been thinking about it in a little bit of a different way, and I wanted to see what you think of this small twist on that. I think only a primary care-led system will work. And that is because unless primary care is in the driver's seat and directing and coordinating the care, you've had the same experience I have, I'm sure, where every time you have to send a patient out to a subspecialist, you cringe a little bit because you don't know what's going to happen next.
A lot. I cringe a lot. Yeah.
Yeah. And so, and we've seen it time and time again in health systems and hospitals where, okay, they might have lots of primary care, but primary care isn't getting to do its job because it doesn't have the autonomy to do what's in the best interest of the patient. It doesn't get to work directly with the patient in the right ways. And so I like to think of it in terms of primary care led instead of just we need more primary care.
So I mean, I have two comments about that, and I agree. If we truly could lead, that would be wonderful. There aren't enough of us, and we don't have any power at this point. We don't have a good lobbying agency. We have nothing. The cardiologists would laugh at us, even for suggesting such thing. But we need to shift that dynamic. So the first comment I have is back in the era of the HMOs, which we talk about a little in this book. We tried that to some extent, and there was a major pushback. The major pushback was from the people in power, and that's what we have to expect. So they have a lot of money and a lot of lobbyists, and they will push back as hard as they can. They will get patients on TV saying their lives were ruined because the primary care doctor said, no, you shouldn't see the specialist. That they have this kind of power. So the HMO movement was an attempt, ironically under Nixon, to make this a little more primary care based. And it did backfire. Maybe they just did it wrong, but something like that would be good. Another model, which Alan and I have actually written an article about in Health Affairs, is the model of direct primary care, which we have all heard of concierge doctors. In fact, in my town, concierge doctors are taking over and they see 500 patients, charge them $2,000 a year on top of what insurance they have to pay. So we're dealing with rich, well-off people. What if we had a system like that for everyone? What if we as primary care took care of 500 people? They didn't have to pay the $2,000. That got paid to us basically as our part of what insurance pays us is some fee per patient, which some places are doing already, and gave us more time, the ability to talk to patients. What right now we're so busy, the idea of talking to patients off hours, even during hours when we don't get reimbursed, and we get sued for what we talk about is something that we don't do very often. But what if we had a more direct primary care system that again was paid by insurance? Insurance would save a ton by doing that, and it would be a primary care system. So they would be seeing us for direct primary care. To do that too, you cannot pay right now a stress test, a nuclear stress test The patient will get a bill for $2,000. Insurance pays $15,000 because there's a facility fee. There's all sorts of fees attached to a stress test. We can't keep doing that. We can't keep paying $35,000 for a stent. Part of the way to move people away from specialty care is stop paying them to do such stupid things and such dangerous things. So we need to change the reimbursement system so they are disincentivized to do all this stuff. And then more people would go into primary care and we would have a primary care based system. So again, I don't know if a primary care led system is in a different model than the HMO model. And if somehow we could deflect the amazing pushback that we're going to get, then it would be great. But I lived through the HMO era, so I'm just a little bit shell shocked by all that.
I mean, I think it can be primary care led without doing it HMO style.
Right, you could do that.
And I'm with you on the direct primary care model. I've been practicing in DPC for a long, long time, and I'll never go back.
Imagine if we could do that for all of us,
Yep.
and that any patient would have access to it. They didn't have to pay the money up front. The insurance company paid it. By the way, the insurance companies would save money if they did that. Studies have shown that. We talked about it in our article. So yeah,
Yes.
that it is another model that can be used to get people into primary care. I asked my kids, I said, if we had a model like that, would you consider it? They both said yes. So not only would it be effective, but it would get people into primary care. And we'd have to control, I hate to say it this way, but we have to control the specialists so they don't keep doing these things. And part of that is to make sure we have a repository of accurate information to the, like the Cochrane, instead of these quality indicators that are absolutely absurd and are based on drug company data. So we need that to be part of any quality program.
I think we're running a little short on time. So what I think we can do is do a little summing up, and then at the end ask people to stay on. I'm going to ask Andy to stay on and have a little more discussion at that point, if that's okay with everybody. So thanks so much to Choma and to Andy for being with us tonight. It's really hard to be on a call together without acknowledging the changes that are coming from Washington. We don't yet know what's going to happen with Medicare, or in particular Medicaid. And let me tell you, people are really scared about the latter, particularly our colleagues in community health centers. And we don't know what these changes are going to mean for communities and for everybody's ability to have a personal clinician in a great practice in every neighborhood and community. As Andy said, it would be lovely if the new administration, in its commitment to a focus on chronic disease, would also focus on making sure that there are primary care clinicians and practices in every neighborhood and community, clinicians and practices who have the time it takes to listen. But no administration in Washington has ever done that. And that's why it's up to us. So don't agonize, to quote my colleague Sarah Pastor, don't agonize, organize. Don't ask what your community can do for you. Just please start a Primary Care for All Americans local work group in your own community if there isn't one yet. Start or join a Primary Care for All Americans state work group. Volunteer, write your state senator or your congresspeople. Tell them about the great opportunity we have together to build a healthcare system that's for people, not for profit, and that starts by providing primary care to everyone. Or just come back in 2 weeks and bring 3 other people or 5 or 10 so we build this moment. Now, there's some people who think we can't do this, but Primary Care for All Americans says, yes, we can. Now, Jay from Texas, I don't want to mess up the pronunciation of your last name.
Okay.
Jay, would you come on for a second and talk about what we want to do in Texas itself? Even though it looks like there's a Golden Gate Bridge behind you.
Okay, that's something I just love, beaches and water, so that's why I have that. And that was only few of the ones I had in Zoom. Very nice to meet, and Dr. Andy, it was very good presentation. The talking about how to listen and hear the patients rather than going after metrics and tests and reporting on quality metrics seems to be the chase that every primary care physician is on. We deliver care on behalf of a lot of the clinics, and we see the same challenge with the primary care physicians. They lose money on the table. They are still not able to listen. Patients are getting frustrated, so on and so forth. With that said, in the state of Texas, I just, I mean, in whatever ways we can do to bind people together, to be able to, leverage some of these concepts in the existing payer systems that they are bound by. Some of them have signed ACO, some of them are part of this, some of them are part of that. They are not going to be able to come out of it that quickly. So within their existing system, how do we make a change? I think that's the first step to look for. Is there some sort of kind of some best practices we can create that they can leverage within their existing practices? That would be a starting point in my worldview. And if that's something we could do, I think that's a starting point for them to then engage others and then also get more satisfaction out of what they're doing with their patients. I mean, nobody wants to do a poor job. I simply feel like they're tied down by all these metrics and the leadership that sits on top of them that wants them to report on this and report on that. And that's a lot. So how do we do that piece is where, I want to explore best practices or, support each other. I don't know. I mean,
Jay
just I
has
would
been
love to
will
hear.
Jay has been willing to step up and say she'll help lead a state work group in Texas. So if you're in Texas or know somebody in Texas who wants to help, please let us know. Just write president at primarycareforallamericans.org, and we'll get in touch with you and build this Texas state work group, which is going to be like the Rhode Island work group, the Massachusetts work group, and the New York work group, only way bigger because Texas is. Chioma.
All right. So in 2 weeks, we will be meeting again. We encourage everyone to invite someone new to get involved in this impactful movement. Let's continue growing and making a difference together. Mark your calendars for our next Zoom meeting, which will take place on April 29th, Tuesday, where we will hear from Dr. Dawn Weaver, retired Assistant Surgeon General, United States Public Health Service. We look forward to seeing you there. Register on our website at www.primarycareforallamericans.org, where you can also check out our local and state playbook. Volunteer and donate to support our cause. Now, I'd like to introduce Lindsay Lopez, our social media lead, who will help everyone to understand how we can all use our socials to help bring primary care to everyone.
Hi, everyone. It's important to follow us on socials to grow our movement and reach as many new people and new audiences as we can. Social media allows us to be seen in places we wouldn't normally reach, and engagement with our posts on LinkedIn, Instagram, Facebook, YouTube really mean a lot to us, whether that's liking, commenting, reposting, sharing. Any interaction really helps increase awareness of our movement. And on our social media, we share the latest on upcoming events, local and state wins, grassroots efforts happening across the country, whether that's in Central Falls, Rhode Island, where our local work group got a resolution passed recently to ensure every resident has access to primary care, or in Queens, New York, where the movement is growing with big grant wins. You'll see more clips from events like these, where experts and community leaders are making a real change. So join the movement, connect with like-minded people, and help build a healthcare system that serves people, not profit. And I'll drop the tag in the chat below so you can check us out on socials and follow us on there. Oh, don't think it's loading, but I can send it out in an email too. Thank you.
All right. Thank you for joining us tonight. We appreciate every single one of you for helping to spread this movement across our nation in order to get the change that you deserve. Please take a moment to complete our survey. The link is in the chat. We want to hear from you. If you would like to talk with members of the leadership team, please stay on our call. Board members of PC4AA will stay to hear your feedback to help us grow as a community. Thank you so much, everyone, and we will see you on April 29th.
Questions for Andy specifically?
Yeah. I'm listening and I don't disagree, but I think I'm a little confused. Just Scott Conard wrote a book called The Seven Numbers. And in my own situation, when I look at, I just finished participating in a 1 year study where I subscribed to a low-fat diet. It was through the University of Michigan, um, and it's through these. It was the American Diabetes Low-Fat Diet as opposed to a low-carb diet. The whole emphasis is on using food as medication instead of as poison, right? Um, but we had lab work throughout the study to measure as measures to see, how our health was improving. And I think that, doctor, I guess my question is, if you're not using these numbers, and I totally get what you're saying from you know, I think physicians have been roped into just because of the social determinants of health and behavior, not having any other recourse to fix high cholesterol. So, I mean, that's what my doctor said. He's like, your cholesterol's high, you need to go on a statin. Well, I didn't want to go on a statin. I knew that if I lose weight, my numbers would improve. But if you throw out numbers, what do you then what? How do you measure? Other than the scale. And,
Well,
and
I
going,
mean, the whole point is that cholesterol, for instance, and we talk a lot about this in the book, is not prognostic of anything. I mean, just as many people get heart attacks with low cholesterol as high cholesterol. There's no benefit of lowering cholesterol. Medicines like Zetia and niacin have been shown to actually lower them wonderfully without improving any outcome. In fact, niacin makes the outcomes worse, even though the cholesterol looks wonderful. So and there is a fellowship now in internal medicine called lifestyle medicine. And I personally am uh, certified in various nutrition education courses and plan to get certified in lifestyle medicine. But I had an argument with them because to them, the end point is lowering A1C and lowering cholesterol. And I said, they don't do that in the blue zones. They're not measuring all this stuff. They're having a very healthy lifestyle, but it's not predicated on fixing numbers. And again, I'll give you an example. We could fix bone density with medicines, but if we keep those medicines going for more than 5 years, the bone density continues to improve, and the fracture risk goes way up, because we are creating bad, dense bone. As I tell my patients, it's like throwing an ice cube at a wall versus throwing a Nerf ball at the wall. Which one's going to break? The dense ice cube is going to break. So our illusion of numbers is what's getting us in big trouble. So going on a good diet is not going to be measurable necessarily. It's not even going to be measurable by the scale because you could gain in muscle. So the scale itself, every NBA player is obese by the BMI criteria. Every NBA player. So if we're gonna go by a scale too, we're gonna be in trouble. It's just the idea that we have to measure things instead of preaching what we know to be the best way to stay healthy and not basing it on measurements. Because I have patients, and I don't preach low fat or low carb. I preach high fat and high carb because the best fats are vegetable fats and oils, nuts, avocados loaded with fat. High fat diets are very healthy. High carb diets are very healthy if you have high fiber diets, as long as you stay away from processed carbohydrates. But that's not those diets aren't going to necessarily move your cholesterol anywhere. What they do is prevent cholesterol from sticking to blood vessels. How do we measure that? We can't. And people are incredibly uncomfortable about that. But that's one of the barriers we have to overcome. If we base our system on measurements, we are never going to be anything other than a specialized drug obsessed system. Because a lot of the dietary interventions do not fix numbers at all.
Andy, if I can jump in for a second, communities have a hard time sorting out the perspectives of different medical experts. And their need isn't necessarily to answer these questions. Their need is to find a way to make sure this essential service, primary care, is available to everyone. Is there a way this perspective helps them get to that ability to get primary care to every single person?
I mean, yeah, ultimately it's going to be a system that is higher satisfaction, to have a doctor that you know is going to spend time with you. The outcomes are going to be better. We have tons of evidence showing the cost of care is going to go down and the outcomes are going to be better. Um, Once we jump to a number system, um, that's it's not going to be the kind of primary care we're talking about. The conversational relationship, patient-centric primary care. So yeah, to get to that level of primary care that everybody wants, a doctor who knows you extremely well, or a nurse practitioner or PA knows you extremely well, and it listens to you and is guided by your own particular needs and wants. That is can't be a number-based system. So the kind of system the communities would want that would save tons of money, um, is not a number-based system. It can't be.
George, I think you had a question about the kind of Oslarian tools we can use to make things better. You want to
Yeah,
pose that question?
yeah, thank you, Michael. And just a sidebar for you and me, we're going to get together on the Connecticut folks, right, at some point.
Yep.
Okay, great. Thank you, Andy. Really great stuff. What you at one of this at the very end slides, you said something like Oslarian tools could help make healthcare better. What kind of tools do you have in mind?
So from two perspectives, one is the medical school perspective, which is going back to what he created at Hopkins before William Welch dismantled it, which was as soon as you walk in the door, first of all, liberal arts education prior to medical school, not necessarily a biology pre-med education, but liberal arts. And then you go to medical school and you're with community doctors, community primary care doctors from day one, learning from them from day one. And then you go to lectures and you say what you learned, and the professor of pathophysiology says, "Oh, that's amazing. Let's talk about the pathophysiology of that condition." That was 4 years of doing that. And so that was Oslarian. And to me, that would be the way students could be taught how to take care of people instead of diseases and numbers. From a perspective of the doctor world, it's the idea that we should not be focused on drugs. We should, Osler had a great line. It said the young doctor prescribes 20 drugs for one problem. The seasoned doctor prescribes one drug for 20 problems. And it's the idea that through our own experience, that we know that lifestyle is most important, that talking to patients is most important. We don't have to fix everything. If we lower their blood pressure and they feel dizzy, we should know that's the wrong thing to do. It's the idea of listening to the patient. Everything is about listening to the patient. The exact opposite of what our system is now, which finds the patient to be a barrier, a subjective barrier to what the numbers tell us. So if you have atrial fibrillation in our system today, you have to be on an anticoagulant, period. Patient doesn't want to do it. I've had 4 or 5 patients kicked out of their cardiologist's office because they wouldn't do it. That's not the Oslarian system. So the Oslarian toolbox is basically patients first, drugs really last.
And do you include giving tools directly to patients in addition to tools that you give to doctors to help them
Well,
basically be, more involved in the program?
I give talks to patient groups 3 days a month in my community, and I tell them exactly that. I said, "You're the guy. You're the ones who need these tools.
Right,
You're the ones who have to go into your doctor's office and understand that it's your choices. You are
right,
allowed to ask questions, and even though they'll label you as a bad patient, there was a Seinfeld episode about that. Where everywhere he went, it was listed bad patient. They closed the
right,
chart. And I even I gave a talk today about hospitals. I said, they're going to make you feel like you better listen or you're going to die, but you can't. They
right.
don't know you from a hole in the wall. So I do try to empower my patients as much as I can. And yes, that's where it has to come from. But they need information.
Arthur Chen.
They need data. They need information. They need a primary care provider who is going to help them in this journey.
Arthur, you had a question.
Uh, Hi. Um, First of all, thank you for this really wonderful presentation, and I look forward to reading your book. And I want to see a lot more of your examples and so on. So I'm a practicing family physician in an FQHC clinic in Oakland, California that serves Asian immigrants. And so I get the Oslerian approach from the standpoint of my having to listen to people coming at health with and healing from a different culture and one steeped in 2,000-year history of approaches that are similar to I think what Oslerian practices would be. Um, I'm just what I'm grappling with right now in listening to your presentation is like eliminating numbers. I mean, Western trained, you know, bicultural by upbringing for me. And is there, and I believe in primary care and making primary care accessible to everyone and primary care led as well. So I'm there. My question really is there a happy median here to negate everything that's come out in the research and so on, even though, yes, it's been medication, drug-based or procedure-based. I mean, choosing wisely was a big step forward, I thought, in teasing out, practices that really work versus those that don't, and cutting, bending the cost curve and so on. So that's really the question. There are things that I feel like we can do that are helpful. I would like to be able to get a patient to get a mammogram, especially one of these new high-tech mammograms that have come out that are much lower on radiation and much more accessible to, all populations,
I
low
mean,
income, otherwise.
we don't want to get rid of numbers. So don't get me wrong. I mean,
Okay.
there's still going to be
Say
measurements
more
to go
about
on,
that.
but we need to know which numbers are effective. I mean, most people don't know this data about mammograms. We did a big video on it on NPR. That actually one out of for people who have lifetime mammograms compared to people who never have a mammograms, 1 out of 1,000 fewer cancer deaths. So if someone is now 55 and they've had all sorts of false positives in their mammograms, and I tell them, yeah, your risk if you don't get a mammogram is really low at this point. Your risk might be higher if you get one because you keep getting biopsies and you're scared to death and you're shaking and your blood pressure's going up. So again, that's not a simple binary either. It's, everyone has a different view of whether to get a test like that. A1C, great test for diabetes, but now they want to push it down till it's almost zero. So and that's one of the dangers of numbers. We know where the happy point is for A1Cs. It's between 7 and 9. All the studies show this. But you go to an endocrinologist, if you're at 7, they will give you insulin. They got to get it lower. They got to get it to 5. So it's the idea of misusing numbers, relying too heavily on numbers. Numbers can certainly be part of the data stream, and Osler said that. He said, but it has to complement your own art of your relationship with the patient, your understanding, your own experience. It has to complement that. It shouldn't replace that, and it shouldn't be more important than that. I've seen so many examples, including my father who just died in the hospital, where he was severely dehydrated. The numbers showed he had congestive heart failure. They diuresed the heck out of him and he died. So it's again, the number trumps the patient, and we just can't have it that way. Numbers should be ordered when they make sense to complement what you're thinking, not just like these random numbers. And there's hardly anything from anticoagulation to mammograms that is binary. I mean, there are risks and benefits to everything. And we have to just be able to as primary care doctors, we have to understand that. That's one of the first problems. And the second problem is we have to explain it well to our patients, that what's out there is not necessarily the only truth. So we have a huge role in helping people to help themselves and to not be so scared if they don't go down every single road that the medical community wants them to go down.
That's really helpful. I mean,
I mean, yeah, places that don't get mammograms don't have.
moderation. I mean,
Yeah, yeah,
not
moderation is everything, right? It's clinical first, number second. And it's kind of the way I describe the Osler Medical School. You see the patient first, then you talk about the science behind it. I mean, that's kind of the patient has to be central. But numbers are there, but they have to complement what you already know from the patient. That's why who could do that? Only primary care can do that. I don't know of any other specialty that can do that.
that's helpful because that wasn't what I was hearing before, and I think that clarification is really helpful.
Okay,
Thank you.
good.
I want to thank everybody who
So let me just say
participated.
something quick, Michael. It is about the art of medicine using evidence-based is what Oslo was about. He wasn't about not the science. It was about the patient as your teacher, though.
Thanks to Andy. Thanks to everybody who participated. Thanks to everybody who's out there trying to make this happen. You know, there's only really one number that matters to me these days, and that's the percentage of the population that has a good primary care relationship. Remembering that the last time it was reasonably studied, it was about 43%. From a public health perspective, that's a disaster because everybody needs somebody who will listen to them. And that's the challenge for all of us is to work together and get away from, sort of the absorption that the medical industrial system has with making money and turn this to an opportunity to provide this essential service to every single person in the United States. And it's something we can only do from the ground up, working in each of our communities ourselves, with those communities, as part of those communities, but not waiting for somebody from Washington or somebody from the state capitol or somebody from, God forbid, an insurance company to say or do something. What matters is what each of us do in our own communities. So thank you all. Please be in touch if you're ready to start a local work group, or if you, like Jay, want to start a state work group. We will help in any way we can as we build this movement. You know, like you heard now, 14, probably 1,500 people across the country, 40 different states. We just got to keep going till we get there. Thanks to everybody. See you all in 2 weeks.